So I'm going to introduce Helen Cox, who's a clinician treating MDR patients at Kailicha, which is also near Cape Town.
Thank you, and thanks for the invitation to speak here. I'm actually not a clinician, I'm an epidemiologist. I just help run the program that we have in South Africa. So I'd like to talk about what efforts are being made to control drug-resistant TB in epidemic settings, and start with a global perspective and then move on to what we're doing in Kailicha in South Africa. So basically, to prevent epidemics of TB, the idea is that we diagnose and treat cases to prevent ongoing transmission. And so I just put this slide up, and the modelers will know much more about this, to suggest that essentially we need to diagnose and treat the same proportion of patients for drug-resistant TB as for drug-susceptible TB, with maybe some variations regarding fitness and whatever. Oops, wrong way. So I think Ted showed these figures yesterday, that there are estimated to be 440,000 MDR cases emerging each year. Unfortunately, we're doing really badly at trying to detect and treat them. So in 2009, only 7% were notified and 5% were actually enrolled on treatment. So quite poor at this point of time. So what are the barriers to actually scaling up treatment? Well, clearly lab capacity, we don't have good diagnostics. The cost of drugs and treatment, very poor treatment outcomes. It takes up to 2 years with a very difficult treatment regimen to treat patients. We don't have good models of care to enable scale up. To date, a lot of programs have been very hospital-based and centralised. There's a lack of guidance internationally. And lastly and importantly, there's a lack of funds and political commitment to actually scale up treatment. So just to go through some of those, this is the percent looking at new cases that get offered DST, drug susceptibility testing and retreatment, and basically less than 10% globally actually get drug resistance testing. So clearly this reflects our lack of diagnostic capacity. In terms of treatment outcomes, these are the latest data from WHO for a number of countries that have reported outcomes. And overall, very poor. Bangladesh is a pleasant anomaly, but overall about 53%. And South Africa is sitting at 42%, but is the only high HIV prevalence country in which any measure of treatment scale-up has occurred at this point of time. So if we look at prices, so this is analysis that was conducted by the International Union Against TB and MSF, and instead of going down, between July 2001 and March of this year, several of the key drugs to treat MDR have gone up substantially in price over that time, and a number have remained stable, and stably at quite expensive prices, namely for PAS. So at this point of time, it still costs between $4,500 and $9,000 USD to treat one patient just on drug costs. And I think this is about what we were paying back in 2003 when we started a treatment program in Uzbekistan. In terms of international support mechanisms, this is an analysis conducted by MSF and PIH and the Treatment Action Group. So these are the three main initiatives to support scale-up: the Green Light Committee and the Global Drug Facility and the Laboratory Initiative. And although the Green Light Committee rated in terms of transparency quite well, both it and the Global Drug Facility rated poorly in terms of effectiveness, because we haven't seen scale up to any degree, and clearly drug prices are not going in the direction, or availability is going in the direction we want it to. And for the Laboratory Initiative, although this has been in operation for several years, there was insufficient information available. In terms of funding, so for this year, in terms of the scale-up plan, there is estimated to be treated 47,000 patients, which is still a fraction of what we need to treat, but there is a 130 million funding gap just for those patients. And in the same analysis on the previous slide, many of the big funders are unable to break down their funding by drug-resistant TB or are not willing to divulge that information. So there's clearly a lot of advocacy needed in this area. And then if we move to Cape Town, again the same picture, and specifically to Khayelitsha, which is a township about 30 kilometres outside of Cape Town, has a population of around 500,000, very high antenatal HIV prevalence of 30%, but a good response in terms of antiretroviral treatment with more than 20,000 people on ART. Certainly Khayelitsha was the first place in South Africa to have public access to antiretroviral treatment. And there are more than 6,000 TB cases registered every year, majority of which are HIV infected. Good DOTS treatment success. But we did a survey in 2008-09 which suggested that if we tested everyone, we would have 400 rifampicin-resistant TB cases just in this sub-district, which is pretty much double what I think you get in the whole of the US every year. And there are 10 health facilities. So this is Khayelitsha. About half the population live in formal housing, brick housing, and the other half in informal housing and shacks. So it's very crowded. So in response to the outbreak in Tugela Ferry, we did a review which found that drug-resistant TB was a mess and there were lots of problems. So we decided to implement a model of care where we would integrate drug-resistant TB treatment into the routine TB program using a patient-centred approach, and namely trying to increase case detection, improve outcomes, and thereby decrease transmission. And this is just to say that most places have an existing routine TB program with very solid pillars, and we were adding various inputs into that to try and integrate the system completely. So just in a nutshell, basically admission only if clinically indicated for patients. Local doctors initiate treatment, but with monthly more expert support. Integration with ART provision, antiretroviral treatment for HIV, so that patients are not attending more than one clinic. Specialist paediatric support, lots of support for patients in terms of counselling and support groups, and daily direct observation at clinics. So how much DRTB is there? Well, this is the survey I told you about, where 5% amongst new cases and 11% amongst previously treated cases, which don't seem that high. But when you actually overlay those figures on what we had in 2008, we would get the 400 cases, which equates to an estimated incidence of more than 80 per 100,000. And again, as Rob said, this is predominantly among new cases, which suggests transmission. So in terms of what we've done, so we started our program sort of late 2007, 2008, and this is what we've done in terms of case detection with, but according to our survey, we're only getting slightly more than half of those patients, and we seem to have plateaued off at this point. And this is mainly because we're only testing patients who are classified as high risk, so previously treated and others. In terms of HIV infection, we've now reached the same level amongst drug-resistant TB cases as we see with drug-susceptible TB, which suggests that cases back here, it was only those that managed to survive long enough to be diagnosed that were detected. Treatment initiation, we're doing much better, getting many more patients onto treatment. So a large proportion of those diagnosed are actually started on treatment. And just to note that 85% last year was started on treatment at their local clinic, which reduces the demand on hospital services enormously. Here is the median days between the sputum sample that told us that they had drug-resistant TB and the time to treatment initiation. And this has come down from more than 2 months to now just about a month, which is a huge improvement and great for reducing transmission, but still not good enough in terms of the people. So 7% of our total cohort die before we can actually start treatment, mostly before we even get the result back. So we still need to decrease that much more. So this is the algorithm. So currently it's only DST for previously treated cases and those failing first line and high risk. So clearly a patient presents We get a positive culture result at 3 or 4 weeks. A line probe assay is done to give us isoniazid resistance and rifampicin resistance. And then if it's resistant to rifampicin, we start a standardised regimen, which has now been strengthened to include moxifloxacin and taurusidone for all patients. But then sometime later, a few weeks later, then we get the conventional DST to the second-line drugs, and then we have to try and individualise the regimen as much as possible. And of course, we have very limited drugs at this point. So just to say that we actually need to start a regimen right at this point as soon as we get the first result, and we can't wait until we get second-line DST. So this is data from last year. So 173 MDR cases. We had second-line DST on 145 of those, and amongst them, nearly a quarter had either ofloxacin, so fluoroquinolone, and/or injectable resistance, making these patients very hard to treat because these are, of course, our main drug classes for treating MDR-TB. But so far, only a relatively small number of XDR-TB cases with both fluoroquinolone and injectable emerging at the start. Most of our XDR emerges through treatment, as Rob pointed out. But we still don't do very well with these ones. Half of these patients actually died before we could start any treatment on them, and the remainder died very soon afterwards. So into treatment outcomes. So these are cases started on treatment in 2009. Obviously, it takes a long time to get results. We have quite high rates of treatment failure, high rates of mortality, of course, 26% default, which is still clearly way too high. It's a very difficult treatment regimen. And in terms of treatment success, if we combine the ones who have finished and those still on treatment, we may be getting 44%. So this is about the best that we can do at this point of time, with 27% overall mortality. But to note here that the cases in purple are the ones that may potentially still be transmitting in the community. So we have clearly reduced this pool down quite substantially by treating. And in terms of default, it may not be as bad as we think. So the blue bars are the percentage of patients who default at various time periods, about a third in the first 6 months and then a third in the next 6, and quite a lot of patients after 12 months of treatment. And the red bars are the percentage of those that have actually culture converted before they defaulted. So we know that a number of them are still culture positive after default if they've had 10 months or 8 months of treatment or more, so a number of them may be cured. And this is a survival graph. This is based on passive surveillance of mortality, so it does have some error associated with it. But at 24 months, we seem to be getting 75% survival, which doesn't sound very good, but compared to KwaZulu-Natal and other parts of South Africa, where 12-month mortality is about 75%, it's actually improved enormously. And clearly that is getting patients onto treatment. So the red bar here is patients who start treatment, so our 18-month survival, 83%, and very dramatic mortality in those that never start treatment. So if we look at our total prevalence, previously we may have been detecting maybe 20% of cases. Now we're detecting 54%, but what we really need is much bigger, at least 80%. And so we need some efforts to go to get there. So if we base, on our 70% detection and 80% cure rate, we need to successfully treat 56% of all the cases in the community. At the moment, our best estimate, and these are rather loose data, is 22%. So some way to go. So community management of drug-resistant TB clearly allows for scale-up. We have much more rapid initiation of treatment. It's more efficient use of human resources, and although we haven't done a good cost-effectiveness analysis, it's much cheaper. We have improved continuity of care, and really importantly, it's a patient-centered approach that is much more ethical and respects human rights. So rather than locking people up as soon as they become diagnosed, we definitely have better overall patient outcomes, but whether we're able to control drug-resistant TB is still an open question. Lots of challenges: insufficient case detection, high default from treatment. This is really, it's very multifactorial. It's often the result of very complex socioeconomic circumstances that these patients live in. And then curtailing ongoing transmission from patients in whom treatment has failed. And these are patients that are infected often with highly resistant strains. But we do need a model that balances the risk to the community and individuals' rights. So, very encouragingly, South Africa is rolling out the expert test, which is a much better test for TB and rifampicin resistance, and it's projected to increase MDR diagnosis dramatically. Hopefully, we'll get it in the next month or two. It's well on the way. So we'll be able to test all of our TB suspects for rifampicin resistance. In terms of treatment default, clearly we're trying enhanced counselling and psychosocial support. We're looking at programs for community-based treatment support. You know, we need to find ways to improve the administration of the injectable agent. It's a very painful injection in your buttock every day for 6 months at least, which is clearly a big factor in terms of default. And then really importantly, for the policy side of things, we need to advocate for trials of shorter, more tolerable regimens that both incorporate some of the new drugs coming through, but also optimise the use of some of the existing drugs. I don't think we've actually done that very effectively. And you know, from our point of view, a 6-month oral regimen would be much, much better, and we'd be able to achieve much more. For failure of treatment, we are now trying to offer a strengthened regimen when patients start to not respond to the regimen we have. So if they haven't culture converted within 4 to 6 months, and that's using some of the old drugs, which are pretty horrible, but also some of the new drugs, TMC 207, under compassionate use criteria that's now coming through. But also, just as important, we're scaling up our support for these patients in terms of palliative care and supportive housing if needed to try and reduce the risk of ongoing transmission from these patients. So I think one of the main messages is that epidemic control is really about diagnosing and curing individual patients, and we can't lose sight of that reality. So this is a blog of one of our patients whose unfortunately treatment has failed, and she's now taking linezolid. She's completely deaf from the injectable and has had to stop all of her studies. And I think it's very important. So what do we need for the policy people? Well, we need better diagnostics. Point of care would be ideal. We need to scale up treatment, and if it's got any chance of actually reaching everyone who needs it, it needs to be decentralised and community-based, integrated. We need a simplified and I think a standardised regimen that is able to be fitted into a scaled-up treatment regimen program. We need cheaper drugs and international support in terms of money. And just to end with some acknowledgements across the City of Cape Town, Western Cape Province, the National Health Laboratory Service and the staff, and last but not least, are the people suffering from drug-resistant TB. So thank you.